Actually, Amanda's up there, so we can get started because Amanda's out in the atrium. Have a seat. I'm going to have Dr. Sikowski. Either one is fine. Dr. Escobedo, right here. Dr. Hildebrand. And Dr. Hildebrand right here.
Do you want me?
Let's do that right at the end. Let's, and just to let the media know, as soon as we're done, we're going to have a few remarks. We'll take some questions, and then afterwards we have the RET cam with us, so we're going to demo that for you. And we have some images of what you would see from the RET cam on a computer screen that you can shoot as well. So we'll do that right after we complete the Q&A. Okay. With that, I'm going to bring Dr. Greg Skuda, who is President and CEO of Dean McGee, up to do the introductions. Thank you.
Thanks, Teresa, and good afternoon to everyone. The results of a major study on the role of telemedicine in detecting retinal disease in premature babies have just been released by the National Eye Institute. The OU Health Sciences Center was one of 14 centers involved in the study. To inform us about retinopathy of prematurity, or ROP, and the results and impact of the study, we have two ophthalmologists from the Dean McGee Eye Institute, Drs. Michael Sikowski and Lloyd Hildebrand, and the neonatologist, Dr. Marilyn Escobedo. All are professors at the OU Health Sciences Center. We'll also hear from Ashley Spencer, the mother of twin sons with retinopathy of prematurity. First, we'd like to hear from Dr. Michael Sikowski, professor of ophthalmology at the Dean McGee Eye Institute and the Department of Ophthalmology at the OU Health Sciences Center. Dr. Sikowski.
Thank you very much. What I'd like to do first is just give you a brief overview of the disease ROP, how we constructed our study, and some of the highlights of the results. ROP, or retinopathy of prematurity, is a disease where the blood vessels in the developing retina stop forming normally. Usually, right after a term birth, even at that point, the retina is not fully developed with respect to its blood vessels. So when a baby is born prematurely, the blood vessels may cover only half of the retina, or even less in some cases. Today, we have about 50 to 60,000 premature infants born in the United States, and about half of them get ROP. ROP is now ranks 13% in the cause of legal blindness for children in the U.S. One of the reasons this study was done was because of the problems with the clinical profile of this disease and providers to take care of it. It's a fairly rapid moving disease when it gets bad, and when the disease is becoming severe and close to treatment, really in some cases are only a few days the window is where the baby can be successfully treated and preserve vision. Treatment at this stage in our knowledge of the disease is usually laser therapy and occasionally an injection of medicine into the eye. So the disease is rapidly moving with a short window. Then we have an access problem in that there are fewer pediatric ophthalmologists being trained nationally right now, and there's a smaller group of them who are adequately trained or comfortable taking care of babies with ROP. For that, you could also translate that to the developing countries, where the availability of a pediatric ophthalmologist or someone specialized in ROP is very, very low. So the study was done to see if imaging the baby's retinas with a special camera, which you'll see later, that could take pictures and send them electronically to a reading center somewhere where a person, either a physician or even a non-physician, could be trained to read these figures accurately to identify the babies that are high risk that they might need to send the ophthalmologist to take care of them and treat them. We recruited patients for 2.5 years here at Children's Hospital, and our center is responsible for just under 200 of the 1,257 babies that were imaged in this study. All these kids weighed less than 2 3/4 pounds at birth, and the mean gestational age was only 27 weeks gestation. Each baby had about, on average, 3.5 imaging sessions from the camera, and if we look at the whole study together, we had over 5,500 different groups of images that were uploaded and read by experts. The results were very positive. There was a 90% sensitivity of readers being able to identify babies who needed to be checked for severe ROP. And if you look at the subgroup of kids with severe disease that actually required treatment, 98% of the time, the images and the readers of the images were able to identify those babies, so it was highly positive in that regard. Interestingly also, about 45% of the time, the combination of the camera with the readers was able to pick up disease on average 2 weeks earlier than the live ophthalmologist did. So we're very excited about the results of this study and the implications it may have. So at this point, I'd like to turn the podium over to Dr. Hildebrand, who will discuss some of the information technology aspects of the study.
Thanks, Mike. What I'd like to do is talk to you a little bit about what's required to put a system like this together, because we can image the patients, and once we image the patients, we have to send the data to a centralized reading facility where graders can then look at these images, and then we have to have algorithms that determine whether or not they have severe disease. So the first part of this is once the babies who are at risk are selected, we had to take their images. And so we had to train imagers, and we had to set up a protocol for taking those images. And so we took a 6-image set of each eye, and those images were then stored on the camera. From there, we sent them, using the internet, we sent them to a centralized data center here in Oklahoma City, where all of the study centers sent their images. These images were then packaged for the data analysis, and they were sent to Philadelphia, where readers were set up to look at these images and specifically look at very key features in the disease that would indicate whether or not it was severe disease. They would document these in an electronic form, and a computer algorithm would then calculate where they were on the risk scale. And if they hit a certain threshold called referral warranted ROP, then that was deemed to be a positive test. So the whole system had to be tied together, both from the camera perspective, the information technology, the software to capture the data, the software to present the data to the readers so that the readers could do this and do this accurately. And it had to be available all the time. So keeping this all up and running was some of the responsibility that we managed here out of the OU Health Sciences Center, in combination with a company that has been doing some telemedicine in other eye diseases called Innovion Corporation. Thanks.
Thank you, Dr. Hildebrand. Next, we will hear from Dr. Marilyn Escobedo, who is the Director of Neonatology at the Children's Hospital at OU Medical Center. Dr. Escobedo.
Thanks, Greg. We're just so excited about the results of this study because in a practical sense, it's going to make a difference to a lot of babies, not only in the United States, but in the world. Obviously, the main thing is that all these babies who are born so small and so young need to be screened for retinopathy of prematurity. And in order to do that, we need people like Dr. Mike here, who has the expertise to examine a baby and determine whether they have retinopathy of prematurity. Well, there are just not enough Dr. Mikes to go around, not in Oklahoma, not in the U.S., and not in the world. So what we're faced with now is that we can make him more efficient and all the other pediatric ophthalmologists by screening in this way that it has proven by research to be accurate and timely. So we just have to set up the systems so that here in Oklahoma, we might be able to send a baby who's been referred into Oklahoma City to a hospital closer to home and have the images done there and sent here. And then if the screening is positive, the baby can be transferred here, or we can get that examination done to see that this baby gets what he needs. And then there are many babies around the world that have retinopathy of prematurity that have no way of getting access to a pediatric ophthalmologist. So it may be that we will be able to screen vulnerable babies in Brazil or in rural areas in other countries in the world that don't have pediatric ophthalmology. So this is going to be a revolutionary way to use telemedicine to provide better care to babies here in Oklahoma, in the United States and around the world.
Thank you, Dr. Escobedo. Ashley and Greg Spencer are the parents of twin sons, Braden and Brody, who were born at 24 weeks and weighed less than 2 pounds at birth. They were both diagnosed with retinopathy of prematurity and underwent treatment at the Children's Hospital. This afternoon, their mother, Ashley, will give us her perspectives and experience with 2 sons with ROP. Ashley?
Hi, my name is Ashley Spencer. This is my husband, Greg, and my 2 boys, Brody and Braden Spencer. They were born at 23 weeks and 6 days, which is really little. They weighed 1 pound 6 ounces and 1 pound 7 ounces, if you can believe it, and they were about a foot long. They had several complications. ROP was one of their big ones. They spent a lot of time here at Children's, and the early detection of their ROP saved their eyesight. So it's one of the things that we're very thankful for, and I'm really excited that it's something that's going to be more available to other families that have babies that are small like they are.
We're going to open it up to questions now. Could you talk a little bit about the issue with pediatric ophthalmology? In centers like ours, babies have access to this. Can you talk a little bit about rural areas, for instance, of Oklahoma, the United States, how that situation compares?
Sure, up here.
Yeah.
Yeah, we are very fortunate here. We have 3 pediatric ophthalmologists on staff here, all of whom are trained in ROP, and 2 of whom are do an active role in the diagnosis and management of ROP. There are a few people in Tulsa who treat ROP as well, but that's it for the rest of the state. None of the outlying hospitals have a full-time staff that do it. There is a private practice in town that takes care of Baptist and Mercy and Norman, but you think about Ada and Lawton and Chickasha and Shawnee. These babies have to go elsewhere. Other rural states are in a similar situation, but even populous states like California or New York, they're well covered in the urban centers, but again, out in the country, they just don't have them. And you think about other areas of the world, they're very underserved, particularly South America and Southeast Asia. There's really maybe 1 or 2 people highly experienced there. So it is a significant global health problem.
And then I have a question for Dr. Hildebrand. At the reading center, I think I was surprised to learn, I anticipated it would be medical professionals who did the readings. And could you talk a little bit about the types of individuals who actually looked at the images and evaluated their?
Yeah, so there was a broad spectrum of people that were involved in the reading. None of them were actually medical, because what we tested them for was their ability to stick to a protocol and look for very specific details inside images. So we actually had art history majors, geography majors that actually had this attention to detail and had the stick-to-itiveness, I guess, to really follow through with the protocol, which is ultimately very, very important in doing this. But having done that and then establishing a valid protocol is what really made it possible for non-clinicians to actually do the reading. Now, there always was a supervising ophthalmologist over it, so if they had questions, they could go and refer them to that. The other thing that we did for a quality standpoint is we took the same image and we had 2 different people read it, and if there was disagreement, then we would adjudicate it, or we would evaluate it, have a 3rd person look at where they disagreed and help them make the decision.
And overall, the accuracy of those individuals in the reading centers was quite good.
It was very comparable to how it's done clinically now, and then we also looked at their ability to detect severe disease compared to ophthalmologists that were reading the images, and those were also very comparable. So it is a very reliable system, and it has a valid way of looking and finding for severe disease.
And then, I'm sorry, but Dr. Sikowski, this question's for you. And could you tell a little bit about treatment? If severe disease is diagnosed, how quickly is treatment initiated and what types of treatment are used?
The standard protocol is that when treatable disease is diagnosed, treatment should be performed within 48 to 72 hours. There's a subgroup of very, very severe disease where treatment is recommended within 24 hours. Most of the time, nationwide treatment consists of laser surgery to the developing retina. A more novel method of treatment that's been used in the last several years is injection of a special medicine into the eye to stop the abnormal growth of blood vessels. It's also used in diabetes and macular degeneration, and sometimes a combination of these is used. Fortunately, most of the time, treatment is fairly successful, usually in around the 90% range. When that doesn't happen, occasionally we have to retreat or repeat a treatment. There are a small group of babies that go on to develop detachment of the retina and need to have intraocular surgery by a retina specialist.
Dr. Escudero, a question for you in terms of neonatology. One of the things that I read talked about we're seeing more of this perhaps because we've gotten so good that we're able to help these very small babies, more of them survive. Is that something you see?
Absolutely. And I think worldwide, that is the issue. There are a lot more premature babies that are surviving in developing countries and around the world where the expertise of pediatric ophthalmologists is not readily available. But even here in the United States, we have seen the mortality of the very tiny baby go down precipitously. So babies like Braden and Brody here 20 years ago would not have survived. And here you can see that they've not only survived, but they've survived well. And but we do have to survey, to screen all these babies who survive for retinopathy of prematurity because they are at risk because of their immaturity and their early birth.
Mom, I hate to put you on the spot, but I know the boys. Can you tell us what their treatment was? Do you mind? I know, because that's the only way they can hear you when they're watching that stream. Can you just talk a little bit about, I know you had a lot of health issues going on, but blindness is certainly something that's
Scary.
scares.
Yeah, it was very scary. We knew that they were being screened for ROP, and actually one of their very first screenings detected it. And like she said, within 24 hours, we had to decide what to do. We actually did the Avastin injections to their eyes, and I know that's experimental and stuff, but their ROP went away, and we haven't had to retreat anything. They never did have any laser surgery to their eye, so they just had those injections once, and then the ROP went away. Yeah.
Any other questions? Okay. With that, I think I'd like to have Michelle. Would you mind bringing out the camera so that the crews can get an idea of how the camera takes pictures? And then, Dr. Hildebrand, you have those images on your laptop. Might I bring that to you? And then any shots. I figure you guys want to get shots of the babies, probably most important. So. Why don't we bring it out to the front? Can we do that? Show it. Do we have enough power to bring it right here? We'll plug in there. Okay. We're still good so far. I think right there.
But this is done with limited.
This is our red cam. It's portable. It can be taken from bedside to bedside using personal precautions. It's a handheld retina camera and also a pedal that adjusts the lighting and the focus. And it's connected to a laptop, and the laptop actually records a video of the entire imaging session. And from the video, we go back and we pick stills, different angles of the retina. We upload it to the reading center where an expert reader then will evaluate it for referral 1 to ROP.
And then this on the screen, guys, is, and you can take turns, but that's the images that will pop up. And Dr. Hildebrand, can you kind of point to that ridge
Sure.
on the screen? You'll probably have to do this a few times.
So what you see here is the retina with the optic disc in the center. And here you can see a ridge. This is where the active disease is occurring, right on that ridge there, which is out on the periphery of the retina. And so we take an image of that, and this is fairly early disease, and as it advances, it gets more and more aggressive.
I'm gonna have you repeat that.
These pictures illustrate what the camera captures, and in the center you see the optic disc. This optic disc is about 1,500 microns, or the size of a head of a pin. And around there you see the blood vessels forming, and the blood vessels radiate out from the center. And as you get out to the periphery, you can see that there's a ridge in which there's no blood vessels that go beyond that, and that's where the ROP is developing. This is fairly early stage ROP, and you can see that ridge developing. Eventually that can get more aggressive. There can be new blood vessels forming there, and then all of the blood vessels start to get dilated. And that's where the treatment and the laser treatment is applied to those areas. I think one other point worth mentioning is just that the camera technology that we use today works well, and it worked very well in this clinical trial, but there are tremendous opportunities to improve on the cameras that we use, and we see new technologies starting to emerge, which I think will make the imaging better. And again, all of this is about getting a good quality image. If we get a good quality image, we can make a good clinical decision at the reading center. So better imaging will give us better results than we've even seen in this study.
Economic component to all of this too, correct? Because it would seem that the cost of blindness I saw in one child is about $1 million over their lifetime. So looking at something like this, which is a camera, a laptop, and a reading center, is this a cost-effective way to prevent blindness?
Part of the study that one of the parts of the components of the study is we're actually looking at the cost effectiveness. And we don't have all of those results yet. Okay. So, but we do anticipate that it's going to be highly cost effective, especially when you take in the economic burden of blindness for a lifetime for a child.
Well, guys, the babies have headed up the stairs. You're going to have to chase them to get your shots. They're climbing. You come back down? All right, it's up to... And on the video that we distributed to you, you actually have a clip of the RET cam being used on a baby in an ICU. So you'll be able to see how this equipment actually looks when it's being utilized with a very small baby. You also have video of Dr. Sikowski actually examining a baby with ROP.
How unique is this experience of Oklahoma? I mean, as you probably saw training.
How do we rate like
How
this?
unique is this system? Is it being used elsewhere?
This system in the study, this was only used in the study, and it